Hi everyone, my name is Victoria. I am a registered kinesiologist here at Cambridge Cardiac Care Center. And today we are going to discuss commonly asked questions about the heart. So these are some of the things that tend to come up a lot from some of the patients in cardiac rehab. So I hope today can give you a little bit more insight into some of these topics. So we'll get started here. Starting off strong, what is an ECG? So an ECG is otherwise known as an electrocardiogram, also known as an EKG. And normally, if I'm presenting in front of the cardiac rehab class, I will ask all the patients, who's had an ECG here before? And everybody raises their hands. So it's a very routine, common cardiac test that's used to measure the electrical activity in the heart. So they put on the little electrodes that's attached to some wires, and then we're looking at the electrical activity. So is your heart beating in regular sinus rhythm? If it's not, what is it doing? It's used to check your heart rate and your rhythm, diagnose heart problems such as AFib or other arrhythmia type disorders, and track heart disease over time. So you can see in the bottom right corner here that there's a normal type of ECG tracing. It kind of looks like a small hill, a big hill, and then another small hill. When there are deviations to this, right, or differences, that's when we may look at diagnosing, certain types of heart conditions or other things like that. So very routine test. Normally it's quite well liked. You just kind of sit there and lay there, and the nurse or whoever would take the ECG. The Holter monitors that many of the patients in our program will complete that they'll normally wear for 24 to 72 hours. These monitors are mini ECGs. As well, when you do a stress test, an ECG is an essential part to that. You'll be wearing that while you're exercising on the treadmill. Okay, so an echocardiogram is another very common cardiac test that is done, and it gives us a wealth of information about the heart. So it is an ultrasound of the heart, and we get a better understanding of the structure, the size, your pumping function or ejection fraction, the valves and how they're working, and whether or not there may be any tissue damage. So very much so a detailed test. The echosonographer will get an image kind of like this on the right side with lots of different details about your heart's structure and function. If you have congestive heart failure or an issue with the pumping or relaxing function of the heart, normally you will probably do an echo quite often, maybe once a year, or even, more frequent, that sort of thing. Another test that is done commonly in cardiac patients is a nuclear stress test. Sometimes we call this a MIBI test. And this test is used to check for coronary artery disease. So what happens is a safe dye is injected into an arm vein, and that's going to help create an image that shows blood flow to the heart. Again, this is used to check for which parts of the heart may not be getting enough blood flow. And then we get an image kind of like something on the right side. The far left side image shows kind of like a full glowing type circle. That would be a good thing, showing kind of like normal perfusion or adequate blood supply to the heart. And then the image on the right would be a positive test, meaning that there may be some sort of, part of the heart that's not getting enough blood flow, likely due to a blockage. And with this test, again, in the name, it's a nuclear stress test. So there is normally a stress component where the patient will get on the treadmill for it. If for any reason the patient is not able to use the treadmill safely, you'll actually be given a drug that's going to help kind of speed up the heart rate and mimic that type of stress response. Okay, and then we also have an exercise stress test. So I always say this is my favorite test, but definitely not many of our patients. And this is the cornerstone of creating a safe exercise program. So on this stress test, you're going to get on the treadmill, and all of a sudden, the nice technician who you thought was your friend has cranked the treadmill incline up like this, and you're moving pretty quickly. So it's going to look at your heart rate, your blood pressure, symptoms, and estimate your kind of cardiovascular fitness. Again, this is how we learn what you're able to do safely for your cardiac rehab program. So we're going to work you really hard. You're going to do your best. I always say for the purpose of cardiac rehab, there's no way to fail this. You just give it your best. And, your first test is your baseline. It's not supposed to be, very, very good. It's as best as you can. And then as you go throughout the program, you're going to complete a couple more. And we hope to see some improvements where you're able to go a little longer next time. This is used to tell us how much exercise you can do safely. So sometimes cardiac patients, their blood pressure might jump too high with exercise, or it might drop too low. Some people might get symptoms of chest pains or dizziness, or sometimes we see changes on the ECG that suggest that we might have to stop the test and slow you down. And then we also have an angiogram. We sometimes call this a cath. This is a very important test for learning more about the health of someone's arteries. And essentially what will happen is a catheter is inserted into the artery in your forearm or groin, depending on your anatomy and what would work for the person doing the test. And essentially we're going to get these X-ray images of the arteries of the heart. So it's a very specific test. We're going to learn a lot about blood flow. We're checking for blockages. And if there are blockages, how big are they? Where are they? And what are we going to do next? So if you presented to the ER with symptoms of a heart attack, so, chest pain, you might feel unwell, you might feel really short of breath and kind of out of sorts, dizzy, sweaty, that sort of thing. And the hospital does a chest x-ray, they do some blood work, and they think that you may be having a heart attack. Normally, they're going to try to get you in for an angiogram right away to look at the health of the arteries. Once you have an angiogram, there's kind of three different options that may happen next. The first option is you get the angiogram and your arteries are pretty clean or free of blockages. The doctor may suggest just to treat you medically with medicines, cardiac rehab, and other lifestyle modification. That's kind of option number one. Option number two may be that while you're getting the angiogram, you may actually get a stent placed at that time. Or option number three is based on the health of your arteries, you may be referred for a bypass or a CABG surgery. Okay, so talking a little bit about what a heart attack is. A heart attack is also known as a myocardial infarction, or an MI is the kind of term that you may hear a lot. And there are a few different types of heart attacks, but we'll keep it pretty simple for the purpose of this lecture. But we know that over time, plaque can develop in the coronary arteries of the heart. And all the time in cardiac rehab, we talk about things that can progress or accelerate plaque development, right? So smoking, high blood pressure, uncontrolled diabetes, high cholesterol, alcohol intake, diet, lack of exercise. These are all going to contribute to plaque formation, as well as other things like family history, genetics, and so forth. But what actually happens with a heart attack is that plaque is going to build up over time, and then that plaque is actually going to rupture. When the plaque ruptures, blood clots travel there to kind of form, and that can actually block the artery and cut off the oxygen supply to the heart. Your heart is a muscle and it requires oxygen to live. So if something's kind of getting in the way and plugging up that artery so blood and oxygen can't get through, you can be cutting the oxygen supply off to the heart. When that oxygen supply is kind of being cut off or limited, that normally manifests as angina or chest pain. Okay, so a coronary artery bypass graft, or a CABG, is a common surgery done to treat kind of multivessel coronary artery disease. And this is normally done in the case when you have multiple blockages, normally of significant size, kind of widespread throughout the heart. It is open heart surgery, so very serious surgery, but bypasses do save lives. And essentially, what the doctor will do is they'll graft an artery or vein from another part of your body, again, the forearm or the groin, and they're going to create a detour for your blood supply through the heart from your aorta to beyond the blockage. So really, we're going to bypass that blockage in the heart. And again, by doing that, we're kind of restoring normal perfusion and blood supply to the heart. The blockages are still there. They're just not causing us as many problems anymore. So that being said, that's why if you've had a bypass, you're still told to, of course, take your nitro spray. If you're getting chest pain that lasts for more than a couple minutes, because the blockages are still there, but we're kind of creating that detour, the rerouting of blood supply through the heart. Okay, so another indication for cardiac rehab is somebody that's had an angioplasty or a stent. So this would take place while you are undergoing an angiogram or a cath. So they take that catheter, they go in through the forearm or the groin. And this is normally done for more localized coronary artery disease. So you may have like a plaque or blockage in one artery or maybe two, and then the rest of the arteries look pretty good. But what they'll do is they'll put this catheter in and they're going to kind of blow up this stent like a balloon. So it's going to pierce through that plaque and then they're going to blow up the stent kind of like a balloon and it's going to crush the plaque and suspend it to the outside of the artery wall. So again, as you can kind of see in this picture here, the plaque is still there, but now it's out of the way because the stent has suspended it against the wall. The problem is, plaque can come back, right? That has a nice ring to it. You can actually do multiple stents within a stent, but the doctor doesn't want to see you back here, right? They hope that you're making, positive lifestyle changes that you learn at cardiac rehab to prevent further plaque progression, right? Again, this would be known as an angioplasty or a stent. And then we know that your heart has valves. So there's 4 valves in the heart: the pulmonary valve, tricuspid valve, mitral, and aortic valve. And these valves are kind of like doors. These doors are going to open and they're going to close to separate the different chambers of the heart. And there are a couple of things that can go kind of wrong with your valves. The first one is a stenosis or a narrowing. Sometimes we call this like a sticky valve, and that's when the valve can't open the right way. So instead of your valve opening like this, it might open kind of only like this, right? And that's going to affect the blood that's leaving through that valve or traveling through that valve. You could also have a valve regurgitation, or sometimes we call this like a leaky valve. That's when your valve doesn't shut or seal properly. So that can cause blood flow to leak out and actually travel the wrong way. Your heart is a very hard-working muscle. We want everything kind of working in tip-top shape. When there's an issue kind of with blood traveling through the heart and the flow of that, it can be related to a valve issue. Your valve can also prolapse or also fall out of place. So depending on the severity of your valve issue, some patients will go on to get a valve repair or a valve replacement. But many individuals actually have some minor valve issues, like a minor leaky valve, and that's actually pretty normal. So one of the tests that we talked about earlier, the echocardiogram, that's the test that we do to also look at the valve. So we're really getting that full picture. But if it's more moderate to severe with this valve issue, that's when an intervention like a surgery may be required. And if you've been told you kind of have a heart murmur, so that's normally detected when the doctor puts on the stethoscope and they listen to your heart beating. Instead of your heart making the normal sound, which sounds like lub dub, that's what your heart kind of sounds like when it's beating. It will sound more of like a whoosh, a whoosh, a whooshing sound if you have a murmur. And that represents kind of choppy blood flow traveling through the heart. Again, it can be a mild valve issue, so normally you'd be sent on for further testing, but a lot of heart murmurs actually don't pose any issue at all. But again, you'd probably have gotten assessed because of that. Okay, and then just kind of finishing up here, we're going to talk more about irregular heartbeats. So again, that test that we talked about right at the beginning, the ECG or the electrocardiogram, that's going to look at your heart rate and your rhythm. And if you have a slow or a fast heartbeat, that's something that we would be detecting on the ECG. You could also have a heart block, which is going to affect the electricity that travels through the heart. So if you look at the image on the right side here, the upper right side, we see that our heart has this pacemaker type cell. This pacemaker cell is called the SA node or the sinoatrial node, and it's a very literal term, right? The pacemaker cell is going to set the pace for the heart. So that cell is what's going to tell the heart to fire the electricity all the way down the heart and then up the walls, which is going to tell the heart to beat or contract. Again, a lot of these irregular heartbeats come from an issue with the firing of electricity through the heart, specifically atrial fibrillation or AFib. And that's when this pacemaker cell is going to fire the electricity or the nerve impulses very erratically. So if the electricity gets fired through, that's going to make the heart beat kind of erratically. And you may get those really high heart rates. Typically, if you're in AFib, you might feel unwell, you feel like your heart's racing, nauseous, you might feel faint or that sort of thing. But really, it's an issue with that pacemaker cell. Some people that have a slow or a fast heartbeat or a heart that kind of pauses when it's beating or between beats may actually go on to get a pacemaker, which is a device that's put in, and that's going to affect that pacemaker cell and help restore that kind of regular sinus rhythm, help correct the timing of the electricity. And then you could also have irregular or skipped beats here and there. Typically, we call these kind of like a palpitation. And palpitations themselves aren't always harmful. If it's sustained or lasting and that is unusual for you, that's certainly something we would encourage you to go to the ER for to get a further assessment. But, many patients will have, a palpitation here and there. It goes away. They felt okay. But if you're getting this kind of like heart racing and it's lasting, you might feel sweaty or dizzy or unwell. That's certainly when we would encourage you to go to ER to get that ECG on, because by the time you get there, it might be gone. And do we put the ECG on and it's normal? So certainly important to listen to your body, kind of your body best and what's usual or unusual for you. So make sure that you are listening to it. So that was kind of our crash course on commonly asked questions about the heart. As always, if you have further questions, make sure that you do contact your cardiac rehab team, and they can, of course, provide a little bit more insight for you, about any follow-up questions that you may have. Thank you so much. I hope you have a good day.